So first of all, just to say that I have no conflicts of interest to declare. So I've been asked today to talk about melanoma during the COVID-19 pandemic, and gosh, this feels like it was more than 3 years ago, doesn't it? These images of those daily briefings that we had to listen to. Even looking at these images now, they produce a bit of anxiety. You know, it was a horrible time, wasn't it? And oh gosh, no, I'm glad we seem to be through the worst of it. I've tried to make the image of Boris Johnson as small as possible there, just to avoid any sudden shocks there. But in September 2022, Joe Biden said the pandemic is over. Now, there hasn't been any kind of official agreement on this yet, but it does feel as though we're in a kind of recovery phase now, doesn't it? Thankfully, it feels as though we're through the worst of it. So where does that leave us, and how does that impact on melanoma care? Surely COVID doesn't cause melanoma, right? But we know there are lots of indirect effects of COVID, and we're becoming increasingly aware of those, okay? And so there's lots of different factors in how it can affect melanoma care and melanoma diagnoses. And mainly those are patient factors, so primarily anxiety, okay? It was terrifying leaving the house, wasn't it? Never mind going to your GP or going to a hospital where we know there are COVID patients, you know, during a pandemic. You know, we're trying to avoid going to these places, aren't we? There's awareness that perhaps the NHS was overwhelmed as well, and perhaps looking at my mole that's changing isn't a priority, which was the wrong thing at the time, but, you know, retrospectively, it's very easy to say that. And there was, you know, obviously sickness as well. We were isolating, we were shielding. And then there was all the NHS staff issues as well. So people were being redeployed to primary, to you know, frontline services, you know, appropriately, which meant that services like, you know, perhaps skin cancer services weren't at 100% capacity. Also, doctors, nurses were all having to self-isolate or perhaps shielding themselves. And we were having to deal with new technology, telemedicine, which, you know, it took a while to get used to, and perhaps there were issues there, and, you know, especially elderly patients accessing the technology required for that. So there's lots of different factors to consider as to how COVID has impacted on melanoma care. So I'm going to be talking today mostly about NDRS data. Like I said, I've been working with the National Disease Registration Service, which is English Cancer Registry National data. All the data that I'm going to be talking about today is openly available, actually. So standard cancer registration takes about 2 to 3 years. So currently, the data we can analyse is 2020 data, and that was only released about 6 months ago. So when you're talking about the pandemic data, that's not good enough, is it? We needed data right here, right now, to understand how it's affecting cancer services. So we had to change the way cancer registration works. So the cancer registration works in that the NHS Health Act in 2012 means that we can collect data on cancer patients for the purposes of research and national statistics. And what we do is we collect pathology data from laboratories across England and anyone with a cancer. We get data feeds on the pathology records. We also get records on multidisciplinary team meetings. So whenever you have a melanoma diagnosed, your case is discussed at a multidisciplinary team meeting, and that means there are specialists there like dermatologists, oncologists, plastic surgeons, who make sure you're receiving the right care. And a summary is written up, and we receive those data feeds as well. And then we also receive data from the hospitals. So whenever you go to hospital, they ask you your age, your ethnicity, and that's inputted into a system, and we have access to that system too. So we use those 3 records generally to register a cancer. Now, normally that's registered by manually by a registration staff who read the pathology reports, read the MDT summaries, and input the data to create a cancer record. But as I said, that takes 2 to 3 years, so we would be much further behind the curve if we tried to rely upon that. So what we did during COVID was develop something called the Rapid COVID Registration Dataset, or RCRD. And that meant that instead of relying upon manual registration of cancer data, we used a computer. You know, everything is now computer assisted, so we tried to do this with the cancer registry too. We developed an algorithm which mostly relied upon the MDT datasets actually to register a cancer. So using those 3 data feeds as before, instead of having someone manually register it, it was done by a computer. And for melanoma in particular, actually, it was quite accurate, better than some of the other cancers that we used it on. And it was shown to be within about 90% of the formally registered data, so we knew it was reliable. But we could report this within about 3 to 4 months, so there's only about a 3 to 4 month lag in reviewing the data compared to the formally registered data, which took about 2 to 3 years. And that's what we needed to understand how cancer care was affected during COVID. So the top line here on the graph shows that that's the formally registered data, and the bottom line there is the RCRD data. So you can see it's pretty accurate for melanoma. It's within about 10%. And you can see in 2020, you can see we've got a reduced number of diagnoses of melanoma by about 18% compared to 2019. So this is a publication that we produced for British Journal of Dermatology, and in the top left graph you can see different cancers and how their diagnoses have been affected in that first lockdown period, and you can see that was where the effect was greatest. You can see that huge trough. And some cancers were affected more than others. So you can see in the yellow line there, that's lung cancer, and that seemed to be affected less than others, presumably because we were doing a lot of chest x-rays with all the patients being admitted with COVID. So we managed to pick up lung cancer better than we did for other cancers. But other cancers like melanoma, which is in pink there, breast cancer and prostate cancer, all reduced to about 50% of what we'd see in 2019 levels. So that was it's the greatest disturbance basically in NHS services ever recorded in the cancer registry, and we certainly weren't prepared for it. So where do we stand now? So this is the latest data set extraction. So as I said, there's a delay of about 3 to 4 months, so I extracted this data in about January, and so we've got data up until about August last year now that we can look at. And first of all, I should say that it's a very wobbly line, isn't it? And that's because melanoma diagnoses are seasonal, actually. So we tend to get a lot more diagnoses in the summer, we get fewer diagnoses in the winter, and that's the same pre-COVID. And that's presumably because in the summer we wear less clothing. So if you're wearing a t-shirt, it's much easier to say to someone, oh, look, it looks like you've got a changing mole there on the back of your arm, than if you're wearing 10 layers in winter like I do in my cold house in Norfolk. And also perhaps that extra UV radiation has an impact as well in the summer. So it's easier to look at the data when we look at it as a proportion of the previous year's activity. So, for example, comparing April 2020 compared to April 2019. So that's what this graph does. And you can see the first lockdown there. So that's that big dip there, isn't it? And that seems to have the greatest effect. And then the subsequent lockdowns, which are those other arrows there, don't seem to have as significant effect. So it's really just that first lockdown which has the greatest effect. What's most striking is that you see this big trough, but we don't see the mirror image of that, where you see a big peak afterwards in 2021, and that's what we're really concerned about. So it looks as though since about May 2021, our services are above what we would see in 2019 levels, but still not as much as we might expect, considering that huge trough that we can see in 2020. Okay. Wrong way. So these are the counts. So in 2019, we had 14,000 melanomas, and in 2020, we only had 11,500. So that's 2,500 almost missing melanomas in the first year of that pandemic. And in 2021, we're back to what we'd perhaps expect. So incidence rates had been increasing at about 3% per year in the previous decade. So 2021 figures are probably where we'd expect to be if we weren't missing 2,500 melanomas. So where did those melanomas go? What's happened? Well, we're worried that those melanoma patients are not attending hospital services, and their diagnosis is being delayed, and therefore, surely, if their diagnosis has been delayed, they're going to present at a later stage, have worse outcomes, have more expensive treatment. So the knock-on effects go on for many years afterwards. So we've already talked this morning about stages of melanoma. So stage 1 and 2 are localized to the skin. Stage 3, lymph node metastases. Stage 4, generally distant metastases. Now, there isn't a huge difference between stage 1 and 2 in terms of the size. So basically, if it's under 2 millimeters or not ulcerated at stage 1, if it's over 2 millimeters or ulcerated at stage 2. So that's not a huge difference, but it does have an impact on your outcomes. And we wondered whether you could find a difference in stage at presentation in our data. So this is the same graph, but broken down by stage. And so 65% of melanomas are stage 1. It's the most common stage at presentation. And you can see here the greatest effect actually is in those stage 1 melanomas. So of those missing melanomas, about 1,500 of them are stage 1 melanomas. Okay. And the other stages don't seem to be as affected. It's difficult because bear in mind here, when you look at the stages in the grey line there, is the unknown stage. And those, so for formally registered data, the proportion of unknown stage is about 15%. In this data, the Rapid COVID Registration Dataset, it's more like about 25%. So there is that limitation of understanding what's happening here, is that 25% of our patients, we don't know their stage, and we don't know how they're distributed. But we can see that the effect is quite significant and much more significant in that stage 1 group. And this is what's the most concerning. So if we look at 2019 compared to 2020 and 2021 data, there's a reduction of stage 1 diagnoses in 2020, the first year of the pandemic, of 22% of stage 1 melanomas. So it's primarily stage 1 melanomas that we seem to be missing diagnoses. And in 2021, that rate seems to go up, so it's about 66% compared to 2019. But what's most concerning is that when you look at 2021 data, stage 2 diagnoses have increased by 28%. So presumably what's happening is a proportion of those missing melanomas, of stage 1 melanomas in 2020, are now presenting a year later at a later stage in 2021. And that's got a significant impact on patients' outcomes. And we can see that data has now been confirmed with the formally registered data as well. So when we look at net survival, which is the kind of gold standard outcome measurement that often doctors quote when we talk about your prognosis in clinic, for stage 1, 5-year net survival, so that compares a patient with a melanoma compared to a patient without a melanoma, okay? And it uses life tables, so we use your expected survival based upon your age, your sex, your deprivation status, location. And so we can say that a patient with a stage 1 melanoma compared to a patient without a stage 1 melanoma has an almost normal 5-year survival, which I love telling my patients. It's great to say that we've got such good outcomes in our stage 1 melanoma diagnoses. But when you look at stage 2, it does have quite a significant impact on your outcomes. So if those patients are presenting at stage 2, a 20% higher proportion in 2021, then their outcome is dropped by almost 20% at 5 years. And also, it's been mentioned several times this morning by Susanna at the very start that, our melanoma care has improved drastically over the last 10 years. And we can see that when we look at mortality rates, so whether melanoma is put on your death certificate if you die as a result of your melanoma. The number of people dying from melanoma has been reducing over the last decade, and we can see that in our numbers. But already we can see in 2020 and 21, we're seeing higher death rates from melanoma than we had to pre-pandemic. So we can see this is already having an impact on our patients, unfortunately. So we know there are also almost 20% fewer referrals for urgent suspected skin cancer, and that kind of matches the roughly 20% lower melanoma diagnoses as well. But somewhat reassuringly is that actually there was minimal change in the proportion seen within 14 days. So at least we managed to continue that service just about throughout the early first year of the pandemic. Although I know that there are impact on patient follow-up, but the target of 14 days to be seen within referral, we managed to just about keep going. So where does that leave us? What can we learn? How do we compare to the rest of the world? And what are the long-term consequences? So there's a systematic review. So when we look at the evidence, we like to look at to compare comparable data sets that have been published. And looking at Europe and American data in about 39 different studies, they found a similar outcome, and that about 20% fewer melanoma diagnoses were made during the pandemic compared to pre-pandemic years, and the melanomas were thicker during the pandemic. But interestingly, in the Netherlands, they've got a big national data set, really good data, and they didn't find that. They found that actually there's no difference in stage of melanoma during COVID compared to pre-COVID. So what did they do differently? Well, we compare excess mortality rates during COVID, then the Dutch team, they've got this little arrow next to there, did much better than the rest of the world as well, actually, and they did better than the UK and the US. So must have been that they managed their COVID cases, they managed their lockdown much better, and that's something we can certainly learn going forwards. So what have we learned and gained? Well, I think we've realised that big, more accessible data is really important, and using it accurately and appropriately as well. I think, as Pippa said, science has won during COVID, and that those rapid and responsive therapeutic and vaccine trials, it was amazing and astounding to see how quickly they could be developed. And I think pre-COVID, that would never have been conceived that we would be able to, develop a vaccine within 12 months and get it in place. Telemedicine, I'm not sure that we're quite on top of that yet, but hopefully I think it will become more and more in use in the future and help our services. Hopefully we can become more prepared. This is going to happen again in the future, isn't it? We need to be prepared for the next pandemic. Joe Wicks, is everyone still doing daily exercises? Yeah? Good. Okay. So what are the consequences? So it's really interesting. So over the last kind of 20 years or so, melanoma incidence has been increasing, like I said, but it's been mostly stage 1 melanomas that have been increasing. And there's been this idea of what really is the clinical impact of that. If the survival is pretty much normal compared to someone without a melanoma, of a stage 1 melanoma compared to someone without a melanoma, what's the clinical outcome of these? Does it matter if we treat them? But and this has been this idea of diagnostic drift. Are we overdiagnosing melanomas, and what might not have been a melanoma 20 years ago and may be called an atypical mole is now been called a melanoma? And do these stage 1 melanoma cases, do they have clinical significance? Well, we've all been recruited to this trial, whether you like it or not, because of COVID, basically. You'd never get ethical approval for not treating a melanoma, but this trial, the COVID, is going to, give us hopefully some of the answers to those questions and show us how important it is to get early diagnosis and treatments, because we can see some preliminary results already, but really it's going to take a few more years until we could see the long-term consequences. So to summarise, there were 2,500 fewer melanomas diagnosed in 2020 compared to 2019. And these patients seem to be trickling back into the system. Recovery appears to be gradual. There's a shortfall in stage 1 and unknown stage melanomas in 2020, and an increase in stage 2 melanomas in 2021, which suggests that there's delay in diagnosis for these patients. And that's got implications on their survival and also the costs to the NHS. The limitations of this is rapidly collected data, so it's not the gold standard data, and the high proportion of unknown tumours. There's just a couple of other things I'd like to mention as well. As I said, this is all openly available, so if you like looking at statistics, and I'm impressed that you're all here at a melanoma research conference, so I'm hoping that you do, then a lot of this is openly available. It's not that patient-friendly, I have to say, but if you like looking at Excel spreadsheets, then it's all available online, and you're welcome to go and have a look. And this is our melanoma incidence and survival data, but there's also the Rapid COVID Registration Dataset. I'd like to thank everyone who's contributed to this data. It's certainly not all my work. And finally, I'd just like to mention that Kaylin Mystery, who's here somewhere over there, is an academic clinical fellow working with me at the moment, and we're trying to develop a research project looking at the molecular genetics of melanoma, and we're looking for patients to be involved in it. So if you're interested, then please do get in contact to be involved in our patient panel for the project development. Thank you.
Excellent.